Okay, welcome back after the tea break. So since we are running out of time, we'll just be clubbing the 3 sessions together. I would request all the 3 speakers to be on stage after the introduction, and request all to please park your questions after, the questions will be taken after the 3rd session is over. So the next session on infection control in critical care by Dr. Sugata Dasgupta. Dr. Dasgupta has been nominated as the critical care expert for Government of West Bengal, and he heads the intensive care services at RGKar Medical College and Hospital, Kolkata. He's the professor of anesthesiology there. Sir, request you to be on stage, please. The next session for the day is by Dr. Shomudeep Chatterjee. Dr. Chatterjee is MBBS Gold Medalist, MD Tropical Medicine and DM Infectious Diseases, AIIMS, Delhi. He is consultant in infectious diseases at Tata Medical Center, Kolkata. Sir will be speaking on common hospital practices affecting AMS. Sir will be joining us soon. The 3rd session is by Dr. Yashish Paliwal. To come, I would request Sir to please come to the stage. Sir will be speaking on how I optimize antibiotic dosing in severe life-threatening infections in ICU. Dr. Paliwal currently is the Director and Head of Critical Care Medicine at Fortis Hospital, Anandapur, Kolkata. Sir, request you to be on stage, please. We'll be having the 3 sessions together, after which the question and answer session will be done. Thank you so much.
Good afternoon. Thank you, WBC, ERC, Medica Hospitals, and Ramakrishna Mission Seva Pratishthan for inviting me in this August gathering. So we have been discussing about about therapeutics, antibiotic selection, and rational use of antibiotics. But my topic today is a bit in the prevention side or in the administrative setup side also, which covers the whole area of infection control. Here we are not treating infections rather we are trying to prevent infections. And as we have heard earlier, and we all know that hospital-acquired infections, once they happen, it's almost a nightmare of every intensivist, every physician. So, being a part of the government of West Bengal, we have been building intensive care units in district hospitals. Right from 2013, under the guidance of late Dr. Subroto Moitro, I had been working there. So I had been wandering throughout the state to raise this intensive care units, level 1 intensive care units in district hospitals, and also level 2 and level 3 intensive care units in district hospitals and medical colleges. So we had to plan a lot within the limited resources in districts, in peripheries, of how to do infection control at the best. In government, we work with poor people. In government, we work with many compromised situations. So we have to be very rational with our resources. We don't have the luxury of doing a procal every 3rd day. We face patients who cannot afford $500 in 15 days of ICU stay. So we have to rationalize treatment, have to base a multitude on clinics, and have to deliver. And probably we are not delivering, at least in my unit, I have a 25% mortality over the last 10 years. And probably that's not too bad. So with this background, I go into infection control in critical care. So why critical care patients are at risk of infections? Because we all know they are mainly aged patients with chronic comorbidities having some acute derangements. They have multiple devices. Many have an endotracheal tube in situ, many have a central line, many have a Foley's catheter, many have a dialysis catheter, and so on. Many have an ECMO catheter. So all devices are there. Many a times there is a long hospital stay, and in intensive care we have to monitor patients quite frequently than ward patients. So there is frequent contact with healthcare personnel of the patients. So these put the patients at a greater risk of infection. And it has been studied widely that the infections, these hospital-acquired or intensive care-acquired infections, when they occur by multi-drug resistant organisms. We had been listening to all these OXA48 and AMC beta-lactamase producing organisms all this long. So there is a high incidence of multi-drug resistant organisms due to selective antimicrobial pressure and colonization pressure. And there is a multitude of all types of multi-drug resistant organisms, starting from Acinetobacter, Pseudomonas, Klebsiella, MRSA, VRE, etc. But the commonest hospital-acquired infections or ICU-acquired infections, or the commonest things we focus for prevention in the ICU, for doing an infection control protocol, are either a hospital-acquired pneumonia or a ventilator-associated pneumonia, either a CLABC, central line associated bloodstream infection, or a central line related bloodstream infection, a catheter associated urinary tract infection, COTI, surgical site infection, SSI, sometimes MRSA bacteremia, and sometimes Clostridium difficile colitis. So I would focus on these very common hospital-acquired infections. There can be a multitude of others, but these are the commonest worldwide. And this has been shown by the epidemiological data over here. WHO has showed that the hospital-acquired infection rate worldwide is around 7 to 12%, and it is more in developing countries and more in ICUs. The 2021 CDC report has shown that in acute care hospitals, these are the commonest infections: CLABC, COTI, ventilator-associated events, surgical site infection, Clostridial difficile, and MRSA bacteremia. Also in long-term care facilities, IRFs, everywhere. And these are increasing. These are increasing, even in America, these are increasing by quite a significant percentage. So we can understand, we have a antibiotic resistance, antimicrobial resistance data from our government hospitals also. We have a website, in government website, where we can see tremendous results of all these bacteria and antimicrobial resistance. So in US, over the last 1 year when COVID was going on, overall there has been a 7% increase in CLABC between 2020 and 2021, largest increase of 10% in ICUs. There has been a 5% increase in COTI in 1 year, largest increase again in ICUs. There has been a 12% increase in ventilator-associated events, pneumonias, observed 12% in ICUs and 16% increase in HAPs just in 1 year, last 2020-2021. There were 14% increase in MRSAs, and there were 3% decrease in the hospital onset of Clostridium difficile infections. So what is this is an US data. So what is our data? This is our publication from Indian Journal of Critical Care Medicine. It is our research from my unit. It was published in 2015, and it showed that yes, in our unit also, our unit, the nosocomial infection rate was 11.98%. This was in 2015. It's 11.98%, and in our case, again, pneumonia, either hospital-acquired pneumonia or ventilator-associated pneumonia was the commonest, followed by catheter-associated urinary tract infection, followed by, and we have quite a low, for some reason, probably for maintenance of good lines, we have quite a low rate of CLABC or CRBSI. So, see, these things, these publications of ours also shows the same trend. This is a publication from in northern India, from Rotak. See the same trend. The commonest is ventilator-associated pneumonia. The second commonest is this is catheter-related bloodstream infection. Our case it was COTI, and third COTI. Among the organisms, in our case also the commonest organism was a multi-drug resistant Pseudomonas. In North India, Rotak again 27. This is multi-drug resistant Pseudomonas. The second commonest in our case was Acinetobacter. Here it is also Acinetobacter in North India. So this menace is going all over the world, and so infection control practices are essentially required for while developing critical care services. So if we just divide the infection control practices or infection control protocols of a critical care unit, I can divide into three headings. Number one are the standard precautions. Standard universal precautions which is applicable for any patient, be in the intensive care, be in the wards, be in the labor rooms, be in the operation theatres. And then there are some transmission based precautions which are mainly demographic features which have a quite a which involve how to space beds, what should be the distance between two beds, what should be the nurse patient ratio. These are all important. See, these are all important because ultimately if we handle 5 patients by one nurse, 5 ventilated patients by one nurse, which we have to do sometimes because of dearth of nurses in government setups, so these increase infections, and these ultimately these increase in infections give rise to multi-drug resistant organisms. So these infrastructural points are very important. Not only reading an antibiogram is important, not only choosing antibiogram important. We have to hit at the bottom just while developing the ICU, where how to space the beds. How many nards per one ventilated patients? How many nards per one ventilated and one non-ventilated patient? All these count. So these are transmission based precautions, and there are some specific precautions on ventilator associated pneumonia and CRBSI. So standard precautions, hand hygiene is the commonest. Most important is hand hygiene. Nothing can replace hand hygiene, and I would say that there is obviously throughout the world there is a low compliance in following the correct protocol of hand hygiene. Next is the personal protective equipment. It's not that not the suit of COVID, but simple gown, gloves, mask. Next, safe injection practices: 1 needle, 1 syringe, 1 time. Next, biomedical waste management. We all know these things. I am just jotting down in a single slide. And then disinfection and sterilization. I am not going into the details because these are known to everybody. I am giving the main points where we have to focus while developing an ICU or while running an ICU, so that the infection control practices are in place, so that the infection control protocols can be followed very easily. So hand hygiene is the commonest thing. At least 50 seconds of hand hygiene. We all know if our hands are visibly soiled, we use soap and water. If it is not soiled, we use an alcohol-based rub. It is around 5% chlorhexidine and 70% alcohol. I am not going into the 5 moments of hand hygiene. These are taught in MBBS, and it is known to every paramedics and nursing staffs. But my point is hand hygiene, and we should teach everybody. See, in government hospitals, we have Kormo Bandhus. These Kormo Bandhus are Group D staffs or scavenging staffs, and they touch the patient most frequently than any nursing staff. While doing a CT, while doing an MRI, while putting a patient on trolley, the Kormo Bandhus, they are illiterate people. They are not very educated. So I have made a protocol of the nurses and junior doctors of teaching those Kormo Bandhus and scavenging staffs the process of the methods of hand washing, of hand hygiene. So nothing can replace hand hygiene as the main infection control procedure in intensive care or in anywhere in the hospital. Prerequisite is obviously we have to bear below the elbows. I am not going into the details of hand washing. The hand washing and hand rub, there is difference. If it is visibly soiled, then we wash. We all know the ways how to wash the hands. And when it is not visibly soiled, then we rub, obviously with around 5% chlorhexidine and 70% alcohol. Next is personal protective equipment, gloves, gown, mask, the simple things. Sometimes we find dearth of supply of gloves in peripheries, but these are important. We cannot touch one patient in ICU, one ventilated patient, care one ventilated patient, and go to another ventilated patient wearing the same pair of gloves. So these are small things, and these costs probably can be afforded. But if we just use this hand wash and gloves maintenance in the proper way, then we can probably save the cost of 7 days of 3 doses of meropenem per day. So these are some observation checklists of hand wash, as for example, hand hygiene and personal protective equipment. So every nursing staff or every doctor doing intensive care should check whether the sink is working. The sink is in situ, where you have a tap which can be operated through the elbow. Around sink, one sink for 5 patients, at least one sink for 5 patients. So these are there. You have to have alcohol-based hand rubs at the entry and exit of the ICU and at every bed head. So these are small things which need to be taken care of. Which need to be taken care of, that you have the correct hand wash at the correct place in every ICU, in every beds. Safe injection practices, one needle, one syringe, only one time. It has been seen that prevention of needle stick injury is an important step to prevent hospital-acquired infections in healthcare workers. It has been seen that during use of shops, there has been 41% of infections. After use and before disposal, there has been 40% of infections. And during and after appropriate or inappropriate disposal of shops, there have been 15% incidence of infections. So there are HIV transmissions, there are HBsAg transmissions. So we have to be careful. And shops container is an essential part of any ICU armamentarium. We have to see that the shops container is not too full, so that spillage occurs. Biomedical waste management, again, it's nothing new. It's all the one green, red, yellow, blue, and you know what is there: general waste, infected plastics, infected waste, and glassware. I am not going into detail, but just please see that these all make up to provide a good infection control practice. My point is that disinfection and sterilization also. High-level disinfection sometimes is needed with 2% glutaraldehyde or Sidex. Intermediate disinfection sometimes is needed. Low-level disinfection is sometimes needed. Autoclave is sometimes needed. ETO is sometimes needed. So we have different things to be sterilized or disinfected in different ways. So this is another domain of infection control where we have to be very careful about disinfection and sterilization. Regarding transmission-based precautions, so these were all standard precautions. Regarding transmission-based precautions, COVID has taught us quite many things about infection control. COVID has taught us about N95 masks. COVID has taught us about FFP2 masks. COVID has taught us about distancing. So COVID has taught us about airborne and droplet infections more clearly rather. So there will be diseases where airborne precautions where the particles of less than 5 microns will be needed. There will be diseases where droplet precautions have been needed, where special air handling and ventilations are not necessary. And there will be diseases where contact precautions will be needed. Just for example, in COVID, we needed both contact and airborne precautions. So these are all transmission-based precautions, and we have to use that proper masks and using proper distancing and using proper rooms also. Here, I would like to say, I would like to request to see that Indian Society of Critical Care Medicine has a position statement of 2020 regarding ICU design. They have revised the earlier one, which was probably a 2007. So it is a revised statement. So while designing a new ICU or while renovating an ICU, you can look at after the ICU design position statement of ISCCM. There it is written that you in a 10 to 12 bedded ICU, you need around 2 isolation rooms. There may be negative pressure isolation for source isolation, as for example COVID or H1N1, these types of patients, where the pressure differential should be around minus 2.5 kPa, and positive pressure isolation as for example for transplant patients and these patients. These are called protective isolations. So what is the guideline given by ISCCM? It's around 10% of the beds, or around 1 to 2 beds in a 10 to 12 bedded ICU should have isolation rooms. Environmental, there is no role of fumigation or those things which we did earlier. So environmental cleaning is important. High quality cleaning and disinfection of all patient care areas with EPA registered disinfectants and detergents is essential. Surface cleaning of walls is twice weekly. Floor cleaning 2 to 3 times per day. And terminal cleaning, that is patient bed area, handrails, monitored GA. syringe pumper ga, everything should be surface cleaned by the proper disinfectant after discharge or death of the patient. This is very, very important. Once the patient goes out of the ICU, just clean everything, including all fomites which is around the patient. Decontaminate any equipment such as stethoscopes, thermometers, trolleys, etc. with the correct solution. Regarding unit size, this is also important. We cannot push in as many beds we want into a small room and do an ICU and then charge relatives 5,000 bucks per day. We cannot. So in level 1 ICUs, this is again following the ISCCM position statement. This is again following the ISCCM position statement. Level 1 ICUs, that is up to 50 beds hospital. In up to 50 beds hospital, the ICU should have 6 to 8 beds. In level 2, 50 to 100 hospitals, 100 bedded hospitals, around 10 to 12 per ICU. You cannot keep 20 patients in one ICU. Okay, 10 to 12 per ICU. If you have to keep 20 patients in one ICU, then you have to make 2 rooms. So these are recommended for level 3 ICUs, where one room will have 10 to 12 patients, but you will have multiple units. Again, these are important. More crowding will give into more infections. Bed space. In India, we cannot follow the American guidelines. So this is the ISSM position statement. For level 1 ICUs, at least 150 square feet, the bed area, bed space area, allowing the movement of trolleys, intubation space, ventilation, etc. around 150 square foot per patient. Level 2 ICUs 150 to 200 square feet per patient, and level 3 150 to 250 square feet per patient. Please remember that you need a 10% extra space beside this patient space area for those nursing station, in-house store, in ICU storage and all those moving areas, trolley ঘুরবে এই সব জায়গার জন্য কিন্তু around 10% extra space লাগবে. So this is important. These are important for infection control, because more and more crowding will give more and more infections. Doctors recommendation is one senior and one junior for a 10 to 12 patient. Heating, ventilation, AC system is important for infection control, where you need to have minimum 6 air changes per room per hour, 2 air changes per hour composed of outside air. For ICUs which are not dormitory-like, which has cubicles, for cubicles you need at least 15 air changes per hour. Other areas may have at least 3 air changes per hour. For dirty utilities, slice, labs, you need at least 5 air changes per hour. Other staff areas, at least 2 air changes per hour. These are important. These are important for infection control, more so after the pandemic era. Central air conditioned systems and recirculated air must pass through appropriate filters. All should be filtered to 99% efficiency down to 5 microns. Recirculated air, if air is recirculated inside, those should pass through HEPA filters. Hand rubs at entry and exit point on each bed, wash basin, elbow operated tap, I have told. So these are infrastructural issues which are general transmission related issues. If we do this, then general transmission will be decreased and infection control will be in a proper place. So with this standard and transmission based, we go into some specific critical care precautions. And the most important thing I would say, it does not decrease ventilator associated pneumonia according to the 2022 IDS Asia guidelines, but it decreases CRBSI and all other types of hospital-acquired infections, CRBSI, COTI, C. diff. So সকালবেলা যে আমরা পেশেন্টকে স্ক্রাব দিই, the daily chlorhexidine bathing is important for all ICU patients. This is a grade 2C recommendation. It decreases the risk of colonization and infection with all types of drug resistant or other organisms with minimal adverse effects, and it may be more effective in controlling certain infections than an active surveillance policy. So in corporates, they have the luxury of doing this chlorhexidine scrub twice a day. I don't have that amount of nursing staff or paramedics to have to do a chlorhexidine bathing twice a day. But where I worked, I have been trained in corporates, in the highest corporates of India and abroad. So they always did chlorhexidine bathing twice a day. So this is important in decreasing all sorts of infections except ventilator-associated pneumonia or hospital-acquired pneumonia. Prevention of ventilator-associated pneumonia. This is the new guideline which has come in 2022. I have request interested people to go into this, the SHIA IDS APIC practice guidelines. Just I am going into some essential practices there are some changes. We need to avoid intubation as if possible. That is more and more in favor of using HFNO or NIV when needed, and COVID has again taught us that. We have to assess readiness to extubation daily without contraindication. We do that in our daily practice in intensive care. We have to take steps to minimize unplanned extubation and reintubations. I always tell my residents that unplanned extubations is a discredit of any unit. Unplanned airway accidents is any discredit of a unit. Bed sores are discredit of a unit. If you had airway accidents or bed sores, then you have to pull up your sleeves and again make your unit more stringent. So take steps to minimize unplanned extubations and reintubations. Avoid fluid overload. Provide regular oral care. So chlorhexidine mouthwash has gone out of practice in 2022 guidelines. It's only toothbrush and doing mouth care with gauze that will do according to the 2022 guidelines. You don't need to change ventilator circuits very regularly. You have to change ventilator circuits only if they are soiled or malfunctioning. You have to prevent condensate in the water traps. We always use cuffed endotracheal tubes in adults. We have to maintain cuff pressure and volume at the minimal occlusive settings, that is around 20 centimeter of water. It's very nice to have a cuff pressure monitor in every unit, and I'm sure good units have that. And suction of oral secretions before each position change, very important, because I have a publication where I have shown that one position change of the patient, which is part of the routine care, decreases the cuff pressure, and once the cuff pressure decreases, there is increased risk of aspiration and there is increased risk of ventilator-associated pneumonia. So whenever you change the position of the patient, please be sure that the mouth is free of secretions. This is one another additional approaches which are not very essential practices. These what I have told are must do, and these are may do. As for example, in an interruption of daily sedation, utilize endotracheal tubes with subglottic secretion. These were subglottic suction. So there is no harm in doing this, but these are not very high quality evidences, but you can use this. Consider early tracheostomy. It's a totally different ball game of timing of tracheostomy. I am not going into this. So what are not recommended in these 2022 guidelines? Prolonged systemic antibacterial therapy, selective decontamination of the digestive tract, stress alpha prophylaxis, oral care with antiseptics and chlorhexidine. These are closed suction. These have gone out of practice. So for catheter-related bloodstream infection, I will request you again to go into the ISCCM position statement for CVC, which is there in the ISCCM website. There's a CLABSI bundle, and hand hygiene is the main thing. Maximal barrier precautions, skin antisepsis, full body drape, daily review of line necessity, optimal catheter site selection, avoid femorals if needed, use subclavian rather than internal jugular, and scrub the hub. Please be very careful while handling the hub. And regarding other infections like urinary tract infection, surgical site infection, MRSA bacteremia, mostly standard precautions which I have told: hand hygiene, personal protective equipment, aseptic procedure while doing asepsis while doing a procedure are enough. So infection control team is important regarding and that should be headed by a microbiologist or ID physician, and infection control team will have many members. Role of the infection control team is to look whether the infection control measures are being properly followed and properly formulated. And it's very important nowadays in our hospitals we have HICC, hospital infection control committees, and we work hand in hand with them. And please, as healthcare workers, take care of yourself, get vaccinated. That is also a part of infection control, because you are our workforce. Complete the hepatitis B vaccine series, COVID-19 vaccines, flu vaccine if advised, and immediately address and report occupational exposures and accidental pricks. Please don't neglect yourself. Infection control in critical care is a total team effort. I have not given the picture of Lionel Messi. I have given the picture of Lionel Scaloni to show that infection control is everyone's responsibility, and it's not only the doctors or only the nurses who is there. Thank you.
Thank you, sir. We'll park the questions after the end of the third session. I would request Dr. Shoumodip Chatterjee to continue with the next session.
Well, Pranam to Sri Ramakrishna Dev Shamiji and Ma Sharoda, and good afternoon to everyone present here. I am Dr. Shomodip Chatterjee. I work as an infectious disease physician at the Tata Medical Center, Kolkata. So I have no disclosures to make pertinent to this speech. Basically, what my previous speakers and from yesterday we have been speaking a lot on antimicrobial stewardship. So what is it? It is basically a set of activities that would promote proper use, optimum use of antibiotics in respect to right drug selection, right dosage, right route, and for right duration. So what are the basic steps to implement in an AMS program? I understand that it may not be very easy to implement AMS, particularly in peripheral and small setups, but you can do your small bits, whatever is possible from whatever I show, that can also help a lot for your patients and for the community at large. So basically, everyone has shown, and I'll also show what a AMS team looks like, but all the members are not always necessary to be there. So you can form a basic AMS team, including your microbiologist who is attached to your hospital, with a treating physician who can provide you with clinician expertise, and maybe the concerned admitting physician and the intensive care in charge. So whoever leads the team has to analyze the situation in which you are standing. You have to determine whatever resources you have, and you can dedicate that to your infection control and antimicrobial stewardship practice. Please remember that antimicrobial stewardship cannot go alone. As Dr. Bhattacharya had told yesterday, it includes antimicrobial stewardship, diagnostic stewardship, as well as hospital infection control to go hand in hand to have proper impact on infection control in your hospital. So you have to assess the situation where you stand, what are the policies in place, what is done with your patients, what are your most important multi-drug resistant bugs, and accordingly you have to go forward to your administration, show the problems, and get a proper approval, because administrative involvement, commitment, and budgetary and resource allocations are very important in an AMS program. Then you will have to assemble an AMS team, which would essentially include a microbiologist, an ID physician if available, if not a clinician who has an expertise in infectious disease, and sometimes an infection control nurse, always needed. Pharmacist is not very easy to get. You should have your treating physician and admitting physician in your team. So you have to organize an infection control team, and then you have to set your goals depending on what problems you have identified. So depending upon the problems you have identified, suppose you find that in a particular unit, particular 10-bedded ICU, you have a lot of ventilator associated pneumonia over the last 6 months, say. So then you have to understand that what is wrong with it, far below the international standard or even the national standards. Then you have to know what you have to do a root cause analysis and find what is the cause, or what are the causes that is leading to such a high rate of VAP in my unit. What is the organism that is causing the most of the VAPs in my unit, and in that way what antibiotics you need to treat those infections. So you have to prioritize everything and set your goal accordingly. So you set a goal like, I'll reduce VAP to 50% of the current rate in next 3 months. For that you would have to design your interventions. So the interventions may include, as my previous speaker was saying, you have to appropriately implement the VAP care bundles, and there may be some other things, small things that you might have noticed in your root cause analysis might be leading to VAP. You have to design your interventions so that such disruptions of the care bundle is not there. Then accordingly you have to say select your performance indicators. Remember, in an AMS program, performance indicators is a must. As Dr. Chakravarti was telling, a routine audit is done and they have various performance indicators. So a VAP rate is a performance indicator. Maybe you can keep length of ICU stay, length of hospital stay, microbiological cure, or your antibiogram, your changing resistance pattern, all this, and obviously antibiotic consumption in various forms. It can be assessed, like DOT, the days on therapy, or daily drug dosing, etc. There are a lot of indicators which you can use as a performance indicator, which will help you to know where you stand when you are putting in place your interventions. whether you are moving towards your goal. Then you have to implement whatever you have strategized to implement into the routine practice. You have to educate the stakeholders, all the admitting physicians, all the nurses that are who are taking care of your patients, or if it's just a unit, then whoever is working in the unit should get proper training of whatever you want to do, and make sure that whatever guidelines you want people to know or to adhere to should be easily available. If there are people who won't understand some complicated guidelines, you can formulate a flow chart, you can make some small posters and keep it at places which are easily accessible, easily visible, so that people can know. Then you have to monitor and communicate the progress of your AMS activities to your reporting authority, because in our country we don't yet have a reporting authority where we have to report our performance indicator of the AMS program. So in each hospital or in small setups, you may have to report your performance to your higher authorities, so that they give you continuous support, continuous resource and continuous funding. Remember, leadership commitment is a very important step in antimicrobial stewardship program. So these are the core components. As I was telling, leadership commitment comes first. That is why it is at the top. So if there is no commitment from the administration, from the AMS team leader, it's a part-time game, then you are nowhere. You are just nowhere and you are wasting your time and resource. Accountability. So whoever is doing the AMS, maybe we don't have ID pharmacists in India. You may train your pharmacist to do your ID rounds, or the infection control nurse. Each one has a defined role. So they have to be accountable in some way or the other. Even your administration has to be accountable for providing you with adequate support. Drug expertise is a must, because you are dealing with all sorts of antibiotics. You must know their pros and cons, their cost, whichever is high cost, low cost, whatever. Everything you should know. The team members should be aware of the drugs that you are using. You must have the capability to take action, or rather your empowerment to take action whenever you find something is wrong. You must keep a tracking in place. So continuous monitoring and periodic audit are mandatory. Then there should be a system of reporting to a person, maybe your HICC chair or the AMS team leader, or even your administration if they are so involved. And the education is mandatory. So continuous training and education activities regarding your antimicrobial stewardship program should go on in your hospital. So I'll go according to case, and we will see the barriers that we come across in implementing the antimicrobial stewardship. The first case, as Dr. Chakrabarti was also telling, this case is quite common. So a 38-year-old engineer was admitted with a history of fever for 3 days and dry cough for 2 days without any localizing symptom. On examination, he was febrile, tachycardic, he had blanchable erythema. Others, everything was within normal limit. There was no localizing sign anywhere. Chest X-ray was ordered, which was normal. Ultrasound revealed GB wall edema. His WBC count was just 1900 and platelets 70,000. So if there are residents, can you think of 2 or 3 differentials? Are there any residents here? No. So we'll proceed. So he was started on ceftriaxone and some IV fluids, and bloods were sent, and he came out to be dengue NS1 antigen ELISA positive. So what do you think was the problem? Why did we start ceftriaxone upfront in such a patient? So probably we have a fear of litigation. If we are missing something, we have a knowledge gap, or there may be competition. If I don't give antibiotics, the patient goes to another physician who will give antibiotics, the next patient will go to him. So these are not expert opinions anymore. So there is a perception that one must empirically treat serious infection whenever we suspect one with some bombarding regimen. Otherwise, we are in for trouble. So it may not be the case always, and there is evidence in which this study was published in from South India, where they found that certain physician factors led to empiric use of too much of antibiotics, which included a fear of an outbreak, absence of proper training and education, which would make the physicians more conversant with an appropriate antibiotic usage, and there was a knowledge gap. And also, as I was telling, there is always a fear of litigation. I'm not giving antibiotic. If I'm missing something, is the patient having febrile neutropenia? I might land up in court. So this fear remains. Coming to the next case, it is in this 54-year-old male was suffering from chronic leukocytic leukemia, and he was on ibrutinib. He presented with fever for 7 days with shortness of breath and hypotension. On examination, he was confused, his BP was not recordable, pulse was extremely feeble, extremities were cold and clammy, he was resuscitated, his count was 76,000 with hemoglobin of 9 and platelet of 3,57,000. LFT was within normal limit, creatinine was normal, he was started on meropenem, colistin, teicoplanin, and after sending appropriate cultures including blood culture. So, can anyone guess what we are dealing with? He was getting a special drug, ibrutinib, which leads to one common kind of infections. So, interestingly, his blood culture flagged the next day, and we grew Cryptococcus species. Then CT thorax and abdomen was done. There was some mediastinal lymphadenopathy, retroperitoneal lymphadenopathy with patchy ground glass consolidations, and a hepatosplenomegaly was also found. Brain MRI was normal, LP was pending at that time, and a bronchoscopy was done, and bronchoalveolar lavage revealed Cryptococcus as well. This patient was then started on amphotericin B, liposomal amphotericin B with flucytosine, but upfront it will not strike in the mind. So knowledge, yeah, it is a problem because we never kept antifungals in mind in a patient who is on ibrutinib, which leads to more of invasive fungal infections. Cost and availability are issues because flucytosine is not readily available. Liposomal amphotericin B, it is very costly. If you go for the best brand, it's very, very costly. So these are all the barriers that we face for this patient as well. So next case is of a 37-year-old male from central Kolkata, presented to the OPD with fever and chills for 5 days. He had visited the hospital 2 days before, and that is on the day 3 of his illness, and he was given some azithromycin as he had some dry cough. When he came on the day 5, his vitals were otherwise stable, his blood parameters looked somewhat like this, chest X-ray was within normal limit, LFT creatinine were also normal. What would you think is the diagnosis? Short-term fever in central Kolkata. Anyone will guess? So in infectious disease, the location of the patient, the occupation of the patient, the background of the patient, that is basically history, is very important. So we all know that central Kolkata is ill known for malaria. So in the blood test that was ordered in his second visit, it revealed Plasmodium falciparum, and he was advised artesunate with sulfadoxine pyrimethamine. Very well, and the patient came back next day saying, I am not being able to get artesunate sulfadoxine pyrimethamine. What should I take? He is febrile and he is having falciparum malaria. So we changed it immediately to artemethyl lumefantrine, and the patient became afebrile. So what do you think is the barrier in this? The availability of antimalarials is a big issue in our city. Unfortunately, because it is so cheap, pharmacies don't tend to keep. Even in my hospital, I had to fight with my pharmacy so that continuous supply of antimalarial could be established. This is unfortunate. So a 57-year-old male smoker is my next case, who was a known case of acute leukocytic leukemia, presented with fever, cough, shortness of breath, which was increasing for a couple of weeks. His CBC, LFT, KFT were all normal. His chest X-ray, CT thorax revealed bilateral patchy consolidation with some ground glass opacities as well. Would anyone guess a diagnosis? Well, a bronchoalveolar lavage was done, and it revealed Mycobacterium abscessus. So he was treated initially with a combination of amikacin, tigecycline, imipenem and clarithromycin for 4 weeks, and was then shifted to oral agents. And his isolate was sent for a drug sensitivity testing to the AIIMS New Delhi, to my teacher. Because in private setup, the accessibility to this drug susceptibility testing of non-tubercular mycobacteria is limited and costly. So after 2 months, I got a report from AIIMS Delhi saying this abscessus was macrolide resistance. Remember that abscesses are notorious for macrolide resistance, and it is known that if you give macrolide in such cases, the outcome will be worse. So we modified accordingly, and then when we modified, we found that clofazimine is not available. It's an anti-leprosy drug which the government has completely taken out, and there is no availability in private sector. When I accessed government sector, they said we give it only for MDR TB and leprosy patients who are registered on the portal, otherwise we can't dispense. So these are all challenges and all barriers to your antimicrobial stewardship. That is what I'm showing. So this study was conducted in, this was a multinational study, I would say. It actually showed that expensive antimicrobials, antimicrobial availability, resistance to changing our current practice and updating ourselves to the upcoming guidelines, and limited diagnostic capabilities across the country are important barriers to implementing antimicrobial stewardship program. So having said all this, we keep forgetting the very basics and most common and easily done things. As my previous speaker was saying, hand hygiene cannot be neglected. This is one thing that is free, easily available, and depends absolutely on your practice, and it can stop spreading of bugs like Candida auris, colistin resistant organisms, and so on and so forth, which are our daily menace. So what does your AMS team look like? So this is how your AMS team should ideally look like, but as I'm telling, even in the best setup, everyone may not be available. So you have to tailor accordingly. A microbiologist may be available who may not be trained in as a clinical microbiologist, but can guide you in some aspects, like providing you with an antibiogram, suggesting drugs for your patient, and so on. You are lucky if you have an infectious disease specialist, because we still seem to be rare in this country. But if you actually do not have a full-time ID physician, many things in your hospital actually get stuck up. You cannot have a proper infection control program in place. You cannot have him participating in all your meetings. So these are problems. ID is a full-time job. But for small setups, you can actually tag in with an ID consultant nearby who can visit you once a while, and you may ask him to attend 1 or 2 meetings and help out. We all are ready to help you out so that we can fight this global menace of spreading antimicrobial resistance. So we do not have ID pharmacists in India, but we can really train our pharmacists to know basics of infectious disease and basics of antimicrobial stewardship. There are a lot of available resources online, as well as some books are available which they can read and be in rounds with you. In a month or in 3 months time, you would know that this person is now competent enough. Dr. Chakrabarty in fact did this in his hospital, and he had trained a few ID pharmacists who became ID pharmacists and later spoke to me as well. So nurses can similarly be trained in, and now infection control nurse is probably there in almost all government hospitals. I think even the government is planning infection control nurse recruitment in a big way. That's a good step forward, I would say. So coming to my next case, this is a case of a 64-year-old gentleman who presented with fever and altered sensorium for 5 days with initial vomiting. There was no history of seizure. He was diabetic but was well controlled on OHS. On examination, he was confused, he was febrile, his neck rigidity was doubtful. Other examinations didn't reveal anything. His vitals were stable. His hemogram looked somewhat like this. So how will you manage? So we would initially like to manage this patient as a patient of acute encephalitic syndrome, but this patient was started initially on meropenem in one hospital, just meropenem, and an LP was planned, rightly so. So what are the issues, do you think, that why was this patient started on an inappropriate dose of meropenem, and that too only meropenem? So maybe there is no hospital policy, or maybe there was some knowledge gap of the emergency medical officer who was dealing with this patient. So yes, so we have to develop hospital-specific guidelines. If you are in a small hospital, you will know what catchment area you cater to and what are the most common infectious problems that your patients come with. So even in big hospitals, we know what are the infectious complications that are most common. So in diagnosis of an infection, you have to first localize the infection, where it is. So you can go by syndromic approach. What kind of a syndrome is it? Is it a communicable acquired pneumonia? Is it a UTI? Is it a ventilator acquired pneumonia? So syndrome wise, then you have to know your bug, which is causing the biggest problem for you. What kind of bug are you dealing with? Then you can integrate all these informations to develop your care bundle. You can develop your own guideline based on national guidelines and scientific data and international guidelines as well, and have your hospital specific guidelines in place. not only will that be enough, when you have that guideline in place, depending on the hospital antibiogram, the most common syndrome, most common organism, you will have to disseminate the information to whoever is practicing in your hospital, so that there is no disparity and everyone knows the right thing. So training again is an important part of this. So general principles of antibiotic use, as you would know, answering the following key questions will actually help you use the best empiric regimen. So what is the diagnosis or the most likely diagnosis? How severe is the infection? What is the risk of infection with a drug-resistant organism in your hospital? Is your patient immunocompromised? Does the patient have any allergy to any antibiotic? And what is the status of the patient's renal or hepatic function? Is the patient taking any other medicine which can interact with the antimicrobial that you are using? These are very pertinent questions and very basic 6 questions which you need to remember when you are dealing with any infectious disease case. Coming to the next case, this is a case of a 47-year-old neutropenic CA breast carcinoma breast patient who presented to our ER with hypotension and confusion. She was intubated and resuscitated with fluids and inotropes. Blood investigations were sent and started on meropenem, colistin, ticoplanin and caspofungin. Chest X-ray ultrasound didn't reveal anything. Blood culture next morning grew gram-negative bacilli. And we do an in-house carbapenem resistance PCR, carbapenem gene detection, carbapenemase gene detection PCR, which gives us report in 3 to 4 hours. So by next afternoon, we knew that she had a gram-negative organism, which was a lactose fermenter, so probably E. coli or Klebsiella, and there was no carbapenemase producing gene. But there was a reluctance in de-escalating her antibiotics, even though she clinically improved. So timely de-escalation is very important. Otherwise, having robust microbiology support, robust team and robust everything goes nowhere. So de-escalation is very important. During your empiric therapy, you have to select appropriate empiric regimen, as I said, keeping all these factors in mind. And when you have your organism isolated, you have to be confident enough. The confidence comes more so when you have an ID clinician in place who would guide you that no, we are dealing with nothing else than this infection and I'm happy to de-escalate. But even if not, you should go by your microbiology results and de-escalate if your patient is doing good and you have a report. So there are, so this is another paper which had actually shown that there are some hospitals, the antimicrobial stewardship policies are in place. There are guidelines in place, but there is somehow reluctance in the part of administration to implement them because maybe there is no strict monitoring from the national or the state level perspective. So, and there may be a lack of team members at times, lack of resources, lack of recruitment. All these things actually hamper your AMS program. And coming to us, infectious disease specialists, the DM infectious disease has been started in 2016 at AIMS. Then CMC Vellore has some seats. Now School of Tropical Medicine and SSKM Hospital have some seats. So we still remain rare as DM specialists, but there are people who are practicing after doing their MD in tropical medicine or general medicine who have apt expertise in dealing with infectious diseases. So there are papers which have shown that when you are treating even a bloodstream infection, just going by your report and asking your lab and giving antibiotics may not be optimum. When you do an infectious disease consultation, there are certain workups needed for certain organisms seen in bloodstream or whatever sites that would actually be done by an ID specialist in the right way, which will improve the outcome of your patients. So this is not a perception, but is a fact. And as we were having discussion in the morning, brands do matter. This is a paper published from my hospital which has actually shown that there are certain generics which, there are certain brands which were very poor in their relative potencies. What is the problem in our country is we tend to jump onto generics without ensuring that their quality control is in place. If there is no quality control, sir, there will be no generic. If you are implementing generics by sticks, what will happen is the public will suffer. AMR, if you are giving a relatively less potent antibiotic, we will end up in developing more resistant bugs, spread of more resistant bugs across the country, and our public health will be in jeopardy. So you have to keep all these points as barriers to implementing AMS in your hospital, because AMS, if it can be your hospital specific, but if you see it in largest perspective, it cannot be restricted to any geographic location. You have to deal with the world as a whole. So the One Health policy, which includes human health, animal health together, has come in place, because antibiotics are used in animals, and what we eat has a lot of collagen, because it is known to build muscle mass in animals. So we are coming across antifungal resistance. Azole resistance is spreading because they are used in farming. So these things have to be kept in mind. If we don't have proper policy, proper law, and proper enactment of the law, we can never go forward and deal with the antimicrobial resistance at any place. Thank you so much for your patient hearing. Thanks a lot.
Thank you, sir. Any questions for sir, because sir will be leaving right now? So any questions? Just sir's session, we'll have the question answer session. Any questions? Okay, so just a moment. I would request Dr. Professor Pradeep Chakraborty, Head of the Department Medicine VIMS, to please be on stage to felicitate Dr. Chatterjee. Any questions for Dr. Sugata Dasgupta? Sir will also be leaving right now. Okay. So request Dr. Chakraborty to felicitate Dr. Sugata Dasgupta, please. Thank you, sirs. We move on to the next session by Dr. Yashish Paliwal.
Good afternoon, everyone, and thanks to WBC, ARC, and RKM Seva Pratishthan and medical hospitals to invite me here. I think we have learned how to start our antibiotics and how to, based on history, examination, and investigation, to start the antibiotics. But unfortunately, that's not enough. We need to get to the right dosage to get it to work. So, as my previous colleagues have mentioned, we have to select the right antibiotic based on the local antibiograms, susceptibility patterns, and where the infection is. And we also have to think whether that antibiotic will penetrate that particular organ or the site of infection. And we also have to make sure that we give it an optimal dosing and we stop it at the right time. To dose correctly antibiotics, we need to understand how to use them. And in this, most important is a pharmacokinetics, means what happened to the drug when it goes inside the body, and pharmacodynamics means its effects on its concentration in the body. Essentially, in case of antibiotics, is the bactericidal activity. So we have to combine these two things together to appropriately dose the antibiotics. So if we are using an antibiotic, there is no point of using it without getting it to appropriate level to have that bacterial killing action. And that is why we need to understand the pharmacokinetics. It is also need to understand where does it distribute, whether it's a hydrophilic drug or it is a lipophilic drug. Hydrophilic drug mainly distribute to the extracellular fluids and intravascularly, while lipophilic drugs will go everywhere and distribute intracellularly. So hydrophilic drugs generally, they have a low volume of distribution and they have a low intracellular penetration, and they're mainly cleared by the renal system. In ICU patient, they are a different lot. They generally have high volume of distribution. That means they will have a fluid overload state. they are septic or trauma patient who will have a fluid resuscitation. They are on vasopressors, or if they are septic, that is what we are treating. So they will have a hyperdynamic circulation, which will increase the renal perfusion and clearance. Lipophilic drugs, they will have a higher volume of distribution, and they mainly have a liver clearance, and they have a good intracellular penetration. In ICU patients, volume of distribution for these category of drugs does not really change much. And examples for hydrophilic are beta-lactams, aminoglycosides, glycopeptides, that mean vancomycin, tacoprenans, linezolid, and colistin. While lipophilics are quinolones, macrolides, lincosamides, or clindamycin or tigecycline. So once we know what kind of drug that we are using, we can choose appropriately based on the particular patient. So it's very important to give the right dosing in that particular context in the patient that we are using, and what they have come with, and what sort of pharmacokinetic and pharmacodynamic changes they may be having. So while we are using antibiotics, we need to understand what is the clearance, what is the volume of distribution, what is the half-life of the drug, what is the maximum concentration of the drug between the drug intervals, and what is the minimum concentration, and what is the area under the curve. That is, after being giving the drug, how long does it last? So there are some drugs which stay mainly in the extracellular fluid, and there are some which distribute throughout the total body water, and there are some which distribute to the tissues. So pharmacodynamics, we understand pharmacodynamics not in context of just MIC of a particular bug, but in relation to the drug concentration, how it goes in the body during its clearance, and the MIC. So if we look at after giving the drug, it reached the peak level and then gradually decreased because of distribution and clearance. MIC is a minimum inhibitory concentration. For the drugs like beta-lactams, what kills the bug is time over MIC. And while in case of aminoglycoside like gentamicin or amikacin, is the peak concentration which determines the maximum killing. And there are other drugs like quinolones, glycopeptides, and tigecycline, whereas we need area under the curve over MIC is the main PK/PD factor which will determine the adequate bacterial killing. While we are choosing it to be above the MIC, it is not enough, because the different in the colony, not all will have same MIC, though we are detecting an overall an average MIC, but there will be some which will have higher MIC, and if we do not give adequate drug delivery, then they will get mutations, and the drug therapy will be inadequate and will fail. So we try to keep it not just above MIC, but above the mutant prevention concentration to eradicate even the first mutants. Of course, if we are not reaching that, and then it will lead to the failure in many cases. So when we are trying to use concentration dependent antibiotic, generally we target Cmax over MIC more than 10, and area under the curve over MIC is more than 100. Say area over the curve under MIC more than 100 or 120 if it is gram negative, maybe a little less if it is gram positive, and time over MIC for it to work, 40% of the time it should be above that MIC level. Of course, ideal is 100%. So these are the targets that we will be looking at while we are treating mainly gram negatives. So of course, we have discussed that there are difference in the PK/PD when we resuscitate those patients with trauma and sepsis. They have a fluid overload, they will have low albumin levels, resulting in more drug-free concentration and increased clearance. And while we are using inotropes and vasopressors, that will lead to hyperdynamic circulation and increased cardiac output, resulting in clearance of the drug. So what will all lead to? It will lead to the underdosing of the drug and failure of therapy and resistance. While at the same time, if they have an organ damage, collateral damage from the primary problem, then they will have a renal dysfunction or liver dysfunction, which will affect their metabolism. And if we do not adjust the dose, that means we will have a higher drug level, which will lead to overdosing, toxicity, and adverse outcome. So I think we have already seen that. So only thing is there are some antibiotics which have a concentration dependent killing with some time dependence. So those are glycopeptides, tigecycline, and quinolones. Though we do not generally like to use quinolones much in gram-negative sepsis because it breeds resistance across the antibiotics. Other thing that we must remember is patients who have normal creatinine values, septic, hyperdynamic circulation. These patients will have augmented renal clearance, and if we give them the normal dosage, then they will just simply pee it out, and there will not be enough concentration, and we will not be able to cure the infection. That comes to the point that how much meropenem is enough. Well, it is tricky. If it is a CNS infection, it's 2 grams thrice daily, every single day. So it's a 6 multiply at least about 10 days. If we have a young patient with a trauma or a young patient with a severe sepsis, we will end up giving at least, if not 8 hourly 1 gram, at least 6 hourly. And we should know how to get to that drug level. We will go by individual drugs. So what do we generally do? To get to the adequate drug level, we like to give the loading dose. And loading dose does not depend on any organ function. It depends on only one thing, which is volume of distribution. And generally after giving the loading dose, first day I would tend to give the full dose without considering the organ function to make sure that my drug level is adequate, because remember the maximum killing of the bacteria happens in first 72 hours or rather first 48 hours. If your drug level is not adequate, then it is likely that is going to take longer and we will have more collateral damage. After that, you must adjust the drug dosage according to the organ which is clearing it. Okay? And if we are using concentration, time-dependent killing antibiotic like penicillins or carbapenems, then we must try to use them as a continuous infusion, because that is what ensure adequate drug level without going overboard on the overall drug, and we will get the best out of what we are giving. And of course, we have to be careful about the renal clearance. And if we can monitor the drug level, that would be ideal, but unfortunately, therapeutic drug monitoring or TDM is not easily available. So for beta-lactams, all the penicillins, augmentins, carbapenems, we have to use loading dose, we have to use infusion, and we have to be careful about the renal functions. Remember, there is no easy way about it. If we have a normal kidney function, normal creatinine, it can be augmented renal clearance. If you have a normal creatinine in an elderly patient, that could be very abnormal. And so the same number will have a different meaning in different context of the patient. If a patient have a renal injury, whether chronic or acute, it's not very easy to titrate the dosage, because if you are checking the creatinine, collecting it, and then adjusting it, you are always doing the catching up game. So there are few other things which you can use, but not everything is available to us. So trying to use the infusions to get 100% time over MIC is the way to optimize this dosage. Aminoglycosides, they are the ones for which we have a maximum amount of data and evidence in terms of doing the drug level and adjusting it accordingly. These are the hydrophilic drug. They have a low volume distribution, renally excreted. So we have to give the same dosage. Only thing changes in aminoglycoside is the dosing interval. You don't change the dose, okay? And we try to get the Cmax over MIC like we have seen earlier is 8 to 10. If we are using gentamicin at the same dose, we are more likely to underdose. And some of the studies say you must use it not 3 to 5 milligram per kg, but up to 7 milligram per kg. And of course, doing the trough levels are important if we can. And there are nomograms so that to adjust this dosing intervals. Vancomycin. Vancomycin is a hydrophilic drug, low volume distribution, renal elimination. But to have it effective, we need to have AUC over MIC over 400. We can use the TDMs to drug levels, though the goalposts have been changing in terms of what sort of adequate trough level we should maintain. Earlier it was 15, then increased to 20, but we can use continuous infusion to optimize its dosage. Colistin, of course. Colistin is a prodrug, is a hydrophilic, low volume distribution, mixed elimination, and all colistins are very different. They, even in the same batch of colistin, their activity can be very, very different. And that is why it is very difficult to get consistent colistin level in the drug if kidney functions are normal. And that is why there is a move from colistin to polymyxin B to get more consistent level of polymyxin without needing a renal dose adjustment as we do in colistins. And of course, therapeutic drug monitoring is not very well effective. We should use the post-HG dose if we are giving colistins. And I think also polymyxin B is a less nephrotoxic agent. Quinolones, we should administer the maximum dose. And of course, we should try to use it single dosage if it is a levofloxacin, and TDS if it is ciprofloxacin. And therapeutic drug monitoring is not very well established for quinolones, but by and large we use quinolones in intensive care practice only when we are worried about the pressure selection bugs coming in, like your Elizabeth Kingia or Proteus or Burkholderia. Well, there are a lot of things happening, so maybe in the future we do the more of the TDMs after giving the loading dose and adjust it either by using the AI or using the nomograms or using a software. So if we look at the dosing software, it assimilates the PK/PD completely, means population-based pharmacokinetics, patient data, and pathogen-specific MIC. So if we have all the information, we can dose our antibiotic in a best effective way. So my take-home message from this is, while we are using the antibiotic, we must use the loading dose, and maintenance dose is as per the organ clearance. Adjust it after 48 hours, not very early on. Keep in mind of the albumin levels and protein binding and the MIC level and PK/PD targets. Use the therapeutic drug monitoring if available to you to manage the toxicity. While we are starting the antibiotics, we should keep a local antibiogram in mind. And patient's body weight, very important. Obese patients, different PK/PD. Underweight, it's not always meropenem 1 gram TDS, so make sure, look at the weight as well, please. Okay, thank you.
So thank you, sir. I would now like to call upon Justice Oshim Banerjee to felicitate Dr. Paliwal with a small token of appreciation. Thank you, sirs. We move on to the next session on antibiotic prescription in children by Dr. Joydeep Chaudhary. Dr. Joydeep Chaudhary is Professor, Department of Pediatrics, Institute of Child Health, Kolkata. Sir, request you on the stage, please.
Good afternoon, everybody. My gratitude to the organizers for inviting me to speak on an aspect which is very close to my heart. And I bring best wishes from Institute of Child Health, Kolkata, from Indian Academy of Pediatrics, and from Infectious Disease Chapter of Indian Academy of Pediatrics. It's quite intimidating to stand in front of a legend like Professor Mukherjee and speak, but I will try. Well, regarding antibiotic usage in children, the ideal situation is the therapeutic use, where we treat an existing infection, or it's a prophylactic use to prevent an infection. These are the ideal scenario. In therapeutic, one is the definitive, where an infection has been proven and we treat, but most often what we do is an empirical, where there is a probable bacterial infection but not proven. So here we have to go by the likely organism and sensitivity. I will just like to illustrate with few of the cases that we encounter, the mistakes that we do. A 36-week gestation baby delivered by Caesar, appropriate for gestational age, no risk factors, was kept in the nursery for observation for 48 hours, but was given IV ceftriaxone and amikacin as it's a precious baby because it was an IVF baby. The baby was discharged but comes back a week later with sepsis due to ESBL, producing Klebsiella pneumoniae. So what has happened? What's the error? Here, giving antibiotics were not required. A high-risk baby, a precious baby, is not an indication for antibiotics. 2-year-old asymptomatic close contact with TB. The baby was on INH prophylaxis, developed fever, cough, weight loss. No further investigation done. Rifampicin was added empirically. Child not improved after 6 weeks. There was massive lymphadenopathy. Gastric lavage proved Mycobacterium tuberculosis. So what was the error here? Giving inadequate number of antibiotics. Whenever a child is in close contact with a TB, the child should be proved to be negative of Mycobacterium tuberculosis, then only an INH prophylaxis should be started. This is the bottom line. 18-month-old, fever, irritability, red bulging eardrum. Of course, it was acute otitis media. The child was put on amoxiclav in correct dose by the pediatrician, but the parents reduced the dose to half as the child developed diarrhea with full dose. 4 days later, the child still running fever, throws a convulsion. CSF grows, H. influenzae, which is beta-lactam, is producing. What's the error here? Giving antibiotic in inadequate doses. Mind you, only the physician or pediatricians are not responsible. It's the pharmacy, the easy availability, the parents, the peers, the neighbors, they all contribute to the irrational antibiotic use. A preterm baby lethargic, had seizures on day 4. CSF suggested meningitis, started on cefotaxime amikacin. The baby looked improved, looked fine at 9 days. Then the parents insisted for an early discharge, so the baby was sent home. Comes back a month later with a brain abscess due to E. coli. So here the error is giving antibiotics for too short a time. There should not be any compromise. 11-month-old child, sudden onset fever, vomiting, 1 day, has watery stool, started ofloxacin ornidazole combination. Another child, 3-year-old boy, cough, cold, vomiting, 1 day, high fever. Mother also has similar symptoms, oral cephalosporin started. Antibiotics started too hastily in these situations. We should have waited. So these are not the indications. 6-month-old baby girl, recurrent bouts of crying with high temperature, not sucking well, refusing to feed. Fever recurs every 2 to 3 hours. Cries whenever the left ear is touched. The ear is painful. So this is acute otitis media, definitely needs antibiotic therapy. But here we have to think of the main causative agents. This acute otitis media in children is most commonly due to either streptopneumonia or H. influenzae or Moraxella catarrhalis. Importantly, this child had a similar episode 1 month back, where the child received amoxiclav at 40 mg per kg. The child recovered well. The pediatrician now has started azithromycin because last time the child responded to amoxicillin in normal dose. Is it justified? No. The standard guideline is 2 to 6 months. First attack of acute otitis media, we must start co-amoxiclav with amoxicillin as 40 to 45 mg or 50 mg per kg. If the child has received a beta-lactam antibiotics in the last 30 days and has a recurrent similar infection, then only there is indication of 90 to 95 milligram per kg per day. Mind you, in pediatric field, there is flood of co-amoxiclav combination with high amoxicillin 90 to 95. This is the only indication, no other indication. This must be followed. Above 6 months, well, it is the standard dose which is recommended, and only very selective cases we might go for high dose, which is not a routine, which should not be a routine practice. So how do we select an antibiotic? Number one, again going back, most of the time we have to give an empiric antibiotic. So we have to think of pathogen, site, severity, comorbidities, drug resistance. All are theoretical, very difficult to justify in clinical practice. But again, we must try as far as possible to go for a single agent. Combination antibiotics should be discouraged usually, unless otherwise the indications I will tell soon. About definitive therapy, definitely requires microbial diagnosis and antibiotic sensitivity test. Now, many a times there is a confusion whether a culture positive is an infection or not. We must be aware of the contaminants, that's the organisms from the skin, the colonizers, and the true infection. This must be segregated. Now, if it's an E. coli, Klebsiella, Streptopyogen, Streptopneumoniae, Pseudomonas, Acinetobacter, this is generally a true infection. We have to take it seriously. If it's Enterococci, Viridans group, coagulase negative staph, there is a possibility of true infection. We have to judge it on a case-to-case basis and not on a blanket basis. But if we get Bacillus, Corynebacterium and others, it is rarely a true infection. It should not be treated. Otherwise, we will generate antibiotic resistance spread. 14-year-old girl, I'll just like to illustrate with a case. 14-year-old, acute onset pain, redness, swelling in the right thigh after a minor wound which is discharging, appears ill with high fever rigors. It was an abscess with cellulitis, pus and blood culture sent. Gram stain showed gram-positive cocci in clusters. So started with Clinda and cloxacillin. Now, do we have to change the treatment now? We get the culture and sensitivity report. It grows Staph aureus, and this is the sensitivity pattern, zone diameter, and the interpretation. Is it right? Well, this is not the right antibiotic sensitivity report, and we should not go by this plus and all this. This plus thing is meaningless. It should not be interpreted from this the degree of sensitivity or resistance. It should be in line with the clinical breakpoints like sensitivity, sensitive, resistance, or intermediate. Sensitive, of course, good chance of success. Resistance, unlikely. Intermediate, well, possibility of success with increased doses, but with other considerations. So, if we have to interpret the drug sensitivity report, it should be resistance or sensitivity like what's there in this slide. So, penicillin and piperacillin goes out resistant of this infection. Now, if we have to narrow the choice further, then we must do the clindamycin sensitivity by confirming with the D test. This is an example of D test. By that only we have to determine the clindamycin sensitivity. Now, despite in vitro susceptibility, Cipro and ceftazidime are not preferred agents for Staph aureus, and that has been proved many a times. So we must not go with Staph. Erythromycin is bacteriostatic, so not at all preferred. Vanco and teicoplanin better reserved for MRSA. So now our choice comes again down. So penicillin, ceftazidime, piperacillin, erythromycin, Genta, Cipro, all are gone. Our choice is oxacillin, cefazolin, and clindamycin. This is how we can narrow down the choice, and we can be very specific. So the drug of choice is cloxacillin. If the child is allergic to penicillin, then only cefazolin should be used. And mind you, now oral cloxacillin liquid preparation is also readily available, so it's very easy to use and it's very effective also. 7-year-old girl, dysuria and frequency of urination. Urine analysis shows pyuria. Patient empirically given amoxicillin, awaiting cultural report. The culture grows E. coli, resistance to amoxicillin, co-trimoxazole, but sensitive to cefuroxime, cefixime, and others. But the patient has clinically improved on amoxicillin. What went wrong with the drug sensitivity test? How did she improve? This is the difference between in vitro and in vivo sensitivity pattern, because the concentration of antibiotic may vary in different sites of the body. The MIC that we get, it is actually reflective of the blood level. But the concentration of antibiotic in the urinary bladder might be different. So we must go by the clinical response and not always by the paper reports. So these are another limitation. When we should go for combination of 2 or more antibiotics, one serious bacterial infection, when the life is at stake, then we should go for the hardest hit, and that is a justification of combination antibiotics. When we have got a mixed infection, say a contaminated wound, a peritonitis, then definitely combination is justified. Pharmacologically, to delay the development of resistance, say the TB, HIV, where a combination antibiotic is preferred to attack the different phase of multiplication of the bacteria. Of course, like the falciparum malaria, when it's always justified to give the artesunate lumefantrine or the other combinations. And when there is true synergy, like penicillin and aminoglycoside in streptoviridans bacterial endocarditis. So these are the genuine indications of combination antibiotics. Now, how to change an antibiotic, escalate and de-escalate. This is another very vital factor, especially in our pediatric practice. I'll give an example again. A 4-year-old boy came to the OPD with some respiratory catarrh, then developed respiratory distress since the morning. It was tachypnea. By the 4-year-old, respiratory rate 60 is high, and saturation is low in room air, 84%. So the child was admitted, hemoglobin low, WBC high, neutrophil high, CRP 90. Patient treated with ceftriaxone, blood culture was sent. After 48 hours, the child was maintaining saturation, but the still running temperature and dyspneic. So to be on the safe side, already 48 hours was passed, so vancomycin was added to ceftriaxone. 4 days went by. The child was still running high temperature, hemoglobin was low, CRP is higher, WBC is higher. Now the resident reported that it is an MRSA, and the final report was due. And this is the chest X-ray. You can see from the previous, the next X-ray has deteriorated further. So we commonly do a USG chest if there is a pneumonia or a developing, because it can detect pneumonic effusion, empyema, septations, and lot many information, a bedside investigation. So USG showed thick fluid with fibrin stance, pleural fluid was tapped, and you can see more than 1,000 cells. So VATS was done and chest drain placed. Culture report came Staph aureus, sensitive to vancomycin, but resistant to oxacillin, clomoxiclav. So it is an MRSA. Now again, we are giving coverage for MRSA. It's a vancomycin. It's a very effective drug, but still there was no improvement after 2 days. High fever. Now we see the WBC is coming down. The child is more sick, but WBC is coming down. Neutrophil is high. CRP is higher. Creatinine kinase was done. It is high. This was the X-ray. So what could be the cause? When MRSA is not responding, this we have to suspect PVL producing penton valentyl leukocidin is an enzyme producing staph, is a toxin producing Staph aureus. Though PVL producing staph is more common in MSSA, but it may be in MRSA also, and this was an example, and this is an actual case. And the child was on vancomycin and clindamycin and showed gradual improvement. Mind you, if it's a PVL producing staph, then vanco will not be effective. We will have to add clindamycin, because clindamycin inhibits the toxin. Why didn't we stop vancomycin? Again, because the child was very sick. So, and it was staph only, MRSA staph. So we could not take the chance of stopping vanco and giving only clinda, but the child improved. De-escalation is the other spectrum. It's a method of narrowing empiric therapy based on both culture reports and clinical improvement, and this is also a very, very important judgmental factor. In the morning, there was some discussion on the acute phase reactants. Well, in our practice, sometimes the procalcitonin is used as a guide to de-escalate the antibiotic therapy. It has that added advantage to CRP. So what are the benefits of de-escalation? Decrease in antibiotic and related adverse effect, also the superinfection, of course cost saving, and MDR bugs in hospital environments are reduced. So de-escalation is very vital for an antibiotic therapy. Then comes the sequential oral, parenteral to oral therapy in pediatric infection. Now there are some antibiotics where we have both parenteral and oral, like azithromycin, ciprofloxacin, though rarely used, linezolid, metronidazole, coamoxiclav, etc. But when we go for antibiotics like ampicillin, sulbactam, ceftriaxone, vancomycin, how do you de-escalate? For ampicillin, it's easy. We can go to amoxicillin. For ceftriaxone, we may go either to cefodoxime or cefixime. Mind you, cefixime, any infection below the diaphragm, one may go for cefixime. But cefixime is not an antibiotic for respiratory infection, because it is mainly a gram-negative coverage. So ceftriaxone we have started. If it's a typhoid, we usually go for oral cefixime. If it's other infection, upper respiratory or respiratory, we may go for cefodoxime. Vanco, of course, if we at all have to de-escalate, we have to go for linezolid. Then the others are as shown here. So I will show you one case of 5-year, 6-month-old, high fever for 5 days, cough, respiratory distress 1 day, had a convulsion, followed by postictal confusion. There was tachypnea, heart rate was high, temperature high, saturation low. There was subcostal retraction, air entry reduced on the right side and everything. So this was the X-ray feature. WBC was 4000, CRP was high, procalcitonin was high, 79. Chest X-ray showed right-sided pleural effusion. Again, USG was done. The child was admitted to intensive care. Ceftriaxone, vancomycin was started. Being it's a very serious looking child, sick looking child, so combination antibiotic was started. Pleural fluid more than 1000 cells, glucose 2, protein 3.8, CSF normal, but the child persisted to be in distress, and this was the chest X-ray. The pleural effusion increased, so the intercostal drainage was put. You can see the tube. And now the antibiotic has been upgraded to meropenem and vancomycin, because considering the clinical deterioration. Repeat WBC 16,000, CRP slightly less, procal less, respiratory PCR was done, and streptopneumonia was isolated, and the child recovered very well on meropenem and vancomycin, recovered by day 8, and so the child was switched on now the wonder drug in pediatric practice, which we are getting, pharopenem. Is it justified? The question lingers. Well, is pharopenem a wonder drug? Now, there are very few indications of pharopenem. Number one, we have to remember that meropenem is a carbapenem, but pharopenem is not a carbapenem. It is a penem. The chemical structure is different, so the spectrum is also different. RTI, pneumonia, acute otitis media, other effective drugs are available, and there is no ESBL production. So pharopenem should not be used in any respiratory infection, pneumonia or acute otitis media. Its spectrum is different, it's a penem. Skin and soft tissue infection, narrower spectrum preferred, like first generation cephalosporin. So again, it should not be used. So what's the indication? The only genuine indication for pharopenem is urinary tract infection, because there is high chance of ESBL production, about 50%. Relapse is common. Though there are few studies, no data on complicated UTI, but it may be considered in non-sick patients as a step down. So that is the probable only indication of pharopenem, and it's not a wonder drug for everything. Advantage oral, spectrum MSSA, pneumococci, E. coli, Hib, Moraxella, Proteus, anaerobes, but it's not effective against Pseudomonas, MRSA, Acinetobacter, Enterococci. So these are the few indications where we use meropenem. So pharopenem cannot be a step down. It is effective against ESBL producers, but resistance by carbapenemase resistance is there by the carbapenemase producers because it is not a carbapenem. So, and one of the main disadvantages is the susceptibility check is not possible because there is no breakpoint and no disc available. So, pharopenem must be used judiciously. So what we always try to promote, and yes, definitely to some extent we have been successful also with all our effort to rationalize the antibiotic therapy at individual level. Decide if antibiotic is needed. One of our very respected pediatrician, he used to tell that whenever you see a patient, you try to diagnose a patient and write the probable diagnosis on the left side. Fever without focus, query viral infection, then we will at least think before writing an antibiotic. Culture of cultures should be encouraged and inculcated. So before starting an antibiotic, a blood culture should ideally be taken. Otherwise, we land nowhere. Of course, the local flora and antibiotic sensitivity is very vital, but we have the limitations that we all are aware. And ensure all orders have formulation, dose, duration, precautions during administration. Otherwise, there may be a lot of misunderstanding. Antibiotic timeout is a concept. Reassessing the need of antibiotics after 48 to 72 hours when we must go back, introspect and think. So, before we ink an antibiotic, we must think that whether we should start an antibiotic. Thank you. Thank you so much.
Thank you, sir. Any questions? Okay. So I would now like to call upon Justice Oshim Banerjee again to felicitate Dr. Chaudhary with a small token of appreciation. Thank you, sirs. So we break for lunch.
I cannot check my temptation. The take-home message that doctor has given to us. Before you ink, think. Thank you.
So we break for lunch now, and we come back at 3 o'clock sharp.